Hey guys, it's Sean Navin with PHS Proud, and have a treat for you today. I had a conversation with retired Rear Admiral Michael Toedt. He is the former Chief Medical Officer for the Indian Health Service, the federal agency responsible for the healthcare of American Indians and Alaska Natives. And we had a really good conversation. We discussed his extensive 30-year active duty career with the Public Health Service. He was, as I mentioned, the chief medical officer for the Indian Health Service. He has experiences on numerous deployments on four hurricanes, responding to the healthcare crises on the reservations in the Great Plains area, and also in Kodiak, Alaska. He has experience in the National Health Service Corps, and also went to USUHS, the Uniform Services University, for med school. So we had a really good conversation. And Admiral Toedt also was the lead person for COVID-19 vaccinations for Native Americans in the United States. And fun fact, very proud fact, that Native Americans have the highest vaccination rate in the country out of other ethnic groups, and Admiral Toedt is very much responsible for that success. So this was a really good conversation, and I hope you enjoy. So we can just dive into it. Definitely
Sure.
excited to have you join me, and it's very nice to meet you virtually. And I was actually, it's kind of funny that I'm thinking about this now, but as I was preparing for this interview, I think I may have met you from afar at a conference. It might have been at COA or something. And
Oh, nice.
was it you that, I think you were telling a story about being out in the Great Plains in your summer whites, and somebody had said something. Does that ring a bell, or maybe I have
It
somebody?
does.
Okay.
So I'm happy to retell that story because it's a fun one. I was an ensign and a medical student in between my first and second year at Uniform Services University. And it was one of my first days, certainly during the first week. And I was walking in summer whites from my housing over to the hospital. And there was a local resident, a native of the Turtle Mountain Chippewa tribe, that yelled out across the parking lot, "Hey, sailor, where's your ship?" And I'm in the middle of North Dakota, and you know, obviously not a sailor.
Yeah, different than being, if you're coming up in USIS, I'm sure you were trained properly with your wearing your uniform, and then going out to the Great Plains, middle of nowhere. Then people are like, who is this with their their summer whites? So that's funny. Well, I'm glad I remembered that correctly. It definitely stuck with me. So, um, I will have introduced you properly, with your bio, which is very impressive before this interview. But if you could just summarize your career as a physician and commissioned corps officer, I think that'd be really great.
Sure, happy to do that. So I started my career at Uniformed Services University. I accepted a commission into the U.S. Public Health Service, commissioned as an ensign. I did consider the other services. We actually have a two-step process, or did at the time when you applied. One is applying to the school based on your academic qualifications, and the other is applying to a service. So you have to do a service ranking. And I ranked PHS number 1. Incidentally, it was number 2 Air Force, number 3 Navy, and number 4 Army. I got a call from USUHS saying, "Congratulations, you've been accepted, and we have a spot for you in the Army." And I said, "No, thank you." And long story short, held out and got a spot in the PHS. Uniformed Services University had 80 slots per class size of about 166 that were in the Army. And so they wanted to fill those slots first. And my class only had 6 PHS officers in it. So I was definitely felt blessed to have been able to get that position, and really felt that way my whole career, that the path that I've taken in Indian health and throughout the public health service has really been guiding for me. So I finished in 4 years at Uniformed Services University and went on to residency in Baltimore. I was at Franklin Square Hospital and did a family medicine residency. I also did a 1-year obstetrics fellowship, which is a fellowship designed for family medicine residents. And I was certified to do cesarean section and minor surgeries that are OB related. And then I started my first in the field position with the Eastern Band of Cherokee Indians in North Carolina. At that time, it was a federal hospital, and I was there for 3 years. When the tribe decided to take over the hospital and exercise Indian self-determination under Title 638 or Public Law 93-638, the tribe made an offer, an extension to the commission officers, but they wanted us to sign on for 2 years. And I was early in my career, uncertain about 638 and uncertain about that process. So I did not continue on when they went 638. I actually went over to HRSA and I was a ready responder. And this was 1 year after 9/11. And I wanted to be better trained and better suited to help in response for disasters. And so great decision in retrospect, because it gave me a chance to go into a different health system. I went to Ripley, West Virginia, to Jackson General Hospital. And it was a rural hospital that had fallen on some hard times and was able to get a HRSA ready responder site. So I was one of 50 individuals at the time that were placed around the country to be a resource for disasters. It was a small program in HRSA that currently doesn't exist anymore, but gave me a lot of opportunity to do longitudinal training in biodefense and readiness, disaster preparedness, disaster response. After 3 years in West Virginia, I was recruited back to Cherokee Indian Hospital, this time as a tribal facility, and found out that indeed that tribal self-determination for the Eastern Band was a great thing. And they had a fantastic growing health system, and was happy to become a part of that and continue the transformation from paper to electronic medical records, from small hospital to more critical access services, upgraded our behavioral health offerings as well, expanded our diabetes offerings. So a lot of good things there. After many years with the Eastern Band of Cherokee, I actually went from a staff physician working in the ER, outpatient, inpatient, but then was chief of staff, clinical director, and a board member for the hospital. I was asked to help with the electronic medical record deployment throughout the Indian Health Service. So that was as a trainer throughout the electronic medical record system across the country. And it gave me the opportunity to see different sites, to understand the different challenges that officers face across the country in public health service, and in particularly in Indian health. And because of that exposure, I was selected to be the agency's chief medical informatics officer, and was on a 1-year detail to Rockville. That gave me some additional exposure at headquarters, and down the road was selected for the Nashville area chief medical officer, which is the southeast region for the Indian Health Service, as well as the Northeast. And then after my time as CMO there, I did spend a deployment actually during that time to South Dakota, and was with the Rosebud Sioux tribe, helping with some hospital work and organizational culture change there as well. And then was on a detail for a couple of months to headquarters when there was a changeover of the chief medical officer for the agency, and then ultimately applied for and was selected for that and served as the CMO for the IHS for 4 years. So that's a summary of a 30-year career. I know it's probably more than you
Yeah.
wanted in one paragraph, but yeah, that kind of sums it up. Married and children along the way, so a lot more to that story, but
Oh yeah.
that's the professional part of it.
Oh yeah. No, there's a lot to dissect there, and very extensive and in such a variety, and which is what I think has always been the value of the public health service trajectory. Even in my short 5 years, just seeing the experience is just very grateful for all that. So, yeah, very impressive. Um, and then, so you're retired. You're now living in North Carolina, and now you've launched your own business called Toedt Health Solutions. Tell me a little bit about that.
Yeah, thank you. So I was able to retire with 30 years of service July 1st, and just a couple of months later now, very busy with my new business. So Toedt Health Solutions was a desire by myself to continue working to serve underserved populations, but to do so in a different way. I'd done so obviously as a federal health executive, but wanted to have more longitudinal and direct interaction with clients to serve their needs, and also to broaden my offerings beyond just Indian health, but also including service to other underserved populations and veterans. So
Hmm.
I'm doing some consulting work as a subcontractor with the VA, working on improvements in the service member disability determination process.
Okay.
I've been doing some work with a pharmaceutical company that's working to increase participation of American Indians and Alaska Natives in pharmaceutical trials. And on the horizon, have some work with some academic institutions working to increase residency programs and training opportunities for physicians and other healthcare practitioners.
Wow, that's great. You're definitely not slowing down. So, yeah, that's good. So I definitely want to circle back to that even more. So that sounds really good. And I was hoping, you know, you provided a nice summary. I wanted just to walk a little bit more down memory lane, and really just kind of see what your experience was as an officer primarily in the public health service, and really get your take on, what is PHS, what was the value for you as in your career. I mean, clearly you've had a lot of different experience, and then just dive into a little bit more of your experience within IHS, the federal agency that takes care of provides healthcare for American Indians and Alaska Natives. There's some very interesting projects that you spearheaded that I definitely would like to just hear more about. So just going back to USUHS. So you went to USUHS 1991, 1995, and so for some people who may not know, explain a little bit more about what USUHS is. There, is it military? Is PHS military? How do you explain that to people?
Yeah, great question. It goes back to that example of being in uniform and mistaken for Navy in the middle of North Dakota.
Yep.
So the Uniformed Services University of the Health Sciences is America's medical school. It is our only federal medical school, and it focuses on educating physicians, nurse practitioners, and graduate health education for the federal services, primarily training doctors and nurse practitioners for service in the Army, in the Navy, in the Air Force, or the Public Health Service. And the Public Health Service angle is the, obviously the one I took, and certainly not the one most people think about first when you hear about Uniformed Services University. It is in a school that is across the street from NIH. It's on the campus of Walter Reed Military Medical Center. So there are a lot of resources in terms of education, the best in military medicine, but also in cutting edge research and public health leadership. And that's really what drew me there, the expertise of the faculty, the devotion of the student body to service, and the access to world-class resources in terms of teaching and expertise. So the Public Health Service is one of the 8 uniformed services. And as a uniformed service, while we're not military and we're not an armed service, we do wear a uniform, and we do serve in various capacities. There are different agencies that individuals can serve in, the FDA, the CDC, the NIH, the Agency for Healthcare Quality and Research, Agency for Substance Abuse, SAMHSA, Substance Abuse and Mental Health Services Administration, HRSA, the Health Resources and Services Administration. So there are just so many different opportunities, and one of those is the Indian Health Service, which is the federal health program for American Indians and Alaska Natives. The Indian Health Service employs individuals both through the Commission Corps system, but also through the federal civil service system. And then tribes have the option as well, if they exercise self-determination and are hiring through those positions, could bring on individuals as tribal employees, direct tribal hires. And then, of course, there's contractors. So we have really a plethora of different avenues that individuals can serve in Indian health. But the path that I chose was one that suited me, and it was to get support for training. There's no fee, there's no loan requirement, but there is a service payback requirement. So I had a service payback requirement of 7 years of active duty, and then another 6 years to be available for inactive reserve. Those requirements have changed and they've updated since then. So if anyone's listening to this and interested in the requirements for service, I do recommend you go to USUHS.gov and check out the requirements there. But certainly that led me into a career of not just medicine and training as a physician, but that dual opportunity to train as an officer and a leader in public health.
There's a lot that I'm just like, I wanted to comment there about what you're saying, a lot of good historical tidbits. I just like to add to that, it's because some people don't know what United States Public Health Service is, which, over time that centralized idea or institution is kind of eroded in the public's consciousness. But a lot of the major agencies we think about today that the public thinks about, like CDC, NIH, are actually the Public Health Service. It's just that those agencies have kind of, the branches have kind of outgrown the tree trunk. Like they're more prominent than the name of the Public Health Service. People just actually don't use that name that much anymore. And then, IHS, a lot of people don't know about, unfortunately, but actually has the most number of officers. So from what I can recollect. So
that's exactly right. Yeah. Mm-hmm.
So there was something that you said that I wanted to circle back to. So with USUHS, just to take a step back. So you applied to USUHS and you applied there wanting to get into PHS. So you must have known about the Commission Corps. So how did you discover it? It's, a lot of people refer to it as the best kept secret. How did you discover it, and what drew you to it?
Yeah, absolutely. So my mother was reading a little magazine insert that came in the Atlanta Journal-Constitution called Parade Magazine. And there was a little article, maybe about 2 by 2 inches, and it said, send your children to medical school for free. And so
Hmm.
she's like, you should check this out, and had a little story about Uniform Services University and how there was no tuition. And I said, yeah, Mom, we're not going to find my career path in Parade magazine in the insert in the newspaper. But sure enough, I took that and looked it up, and remember there wasn't the internet. This is pre-Google. So I actually had to look in my sister's 1960s era encyclopedia, and I read an article about the Public Health Service and what it was, and decided that aligned with my values and interests. So that was the start of it. And really, like you said, being the best kept secret. That's an odd way to find this out. I had other colleagues that had also had family members that had seen something in Reader's Digest. So there were little bits of news and advertisement that were coming out in various places through the years. But it is a shame that that more individuals don't know about it. I do think that the common application process and of course, the internet have helped with information accessibility, and that there is somewhat more awareness of Uniformed Services University. So that's a good thing.
For sure, yeah. I think USUHS is pretty well known amongst the military, or people have a somewhat of an idea of USUHS, but if they hear PHS, they're like, "Oh, what's that?" So that brings me to the next question. So while you were going through USUHS, how did Army, Navy, Air Force, when they found out you're in PHS, what was their perception of that? How did you fit into the other services?
Yeah, so we were readily accepted as members of the Common Uniformed Services family. The faculty, I think, did a good job of helping the different services learn about their sister services. And so there were information sessions and history sessions that expanded on the history of the Army Medical Corps, the history of the Air Force Medical Services, the Navy, and the Public Health Service. So I do feel like that was included in the curriculum. Also, the camaraderie was there. When we, the Public Health Service students in my first year incoming class, arrived on campus, we actually had 2 Naval Academy graduates who were assigned to teach us how to salute properly, how to do some basic formations and marching and so forth. So even before the Commissioned Officer Training Academy and other things that came on later, and the Public Health Service, that USUHS knew that it was important that we have some basic understanding of officership.
Absolutely. And I was curious about that too. So OBC, Officer Basic Course, started, my understanding is around 2006. And before that, there was the Commissioned Officer Training Academy, which is about only like 2 days of training. So what type of officership training did you receive at USUHS and did you go to OBC later? Like, how did that work out for you?
Yes. This was all of my training was pre OBC and pre Commissioned Officer Training Academy. So we did have a 4-week training that was set up at the university and by the university. And I remember Captain Pat Mail took us to West Virginia, to Shepherdstown, where we saw a migrant worker health site. We went to the Coast Guard Academy, and as some of our viewers may find interesting, the Public Health Service provides the public health and medical services for the Coast Guard. So we saw the Coast Guard medical facility at the Coast Guard Training Academy. We also went to the different administrative buildings, and including the Indian Health Service. At that time, the Surgeon General actually had 2 offices. There was one down at the Humphrey Building and then another one in Rockville. And we got to go to both of those offices and actually met with the Surgeon General. There was pretty open access and good exposure to the different agency leaders. So was really blessed to have that orientation when I know that other Corps officers in my same time frame were not getting that sort of introduction. And I think that those experiences are now somewhat well wrapped into OBC. But when they did come out with the Commission Officer Training Academy and OBC, I did some of the certifications that were required, but did not have to go back through a remedial class.
Sure. Yep, that makes sense. So what was the requirements for uniform wear, while you're at USUHS? And then, and this is a really, people get really emotional about this within PHS, especially the newer generation, myself included. I took a lot of pride in wearing the uniform, and think it's very symbolic about, what we represent and what we signed up to do. But, I remember when at my first duty station at the IHS in Albuquerque, people would be talking about, like, oh yeah, we never wore our uniforms, and it used to be just on Wednesdays, like one day a week. And, I about had a stroke. But learning, I think it's important to understand that, again, if OBC just started 2006, that's just 2 weeks of training. Before that, it was just 2 days of training on how to be an officer and wear a uniform. So I think we just have to be empathetic that coming in before that, like, how would you have gotten that training and then just wearing it appropriately? So I think there's just generational changes within the Corps that, we have to understand. So what was the culture with the uniform at USUHS, and also, like, did you have to wear it during your residency? What was the history there with the uniform?
Yeah, a great question. So uniform wear was expected and compulsory. It was required in medical school, and so we actually had, for the most part, had the option to choose between our Class B service uniform or the field utility uniform, which was it's no longer a uniform of the Public Health Service, but this was a camouflage uniform with combat boots, and
like the BDU,
very similar.
Or was it
very similar to the military's BDU, but the
Okay.
Public Health Service called it the FUU, the Field Utility Uniform, which wasn't necessarily the best name.
I'm sure there's a lot of jokes about that.
Yeah, I'm sure. But yeah, as a student, that was a comfortable uniform to wear, so wore that one frequently. But also, I was actually in the salt and pepper uniform before it was retired. As well as the whites, and then for special occasions, and we did have a few. These might be graduations or white coat ceremony or a dining out or a dining in. Then we were in our Class A or our service dress blue uniform, and really that daily wear. I think instilled in me a respect for the purpose of the uniform, as well as the pride that it does instill in you. So I would frequently to and from school, whether I was at a gas station having to gas up or something like that, would get comments from the public about the uniform. And I think the more that we wore it, the more that we were able to educate those around us, and it became more the norm than the exception.
Yep.
It does contrast with the stories that I've also heard, especially post-Vietnam, and I think that's where the uniform wearing significantly dropped off, and there was a lot of antipathy or hatred towards those in uniform, and obviously misplaced, but I think that led to a lot of public health service leadership and really the organization not endorsing the uniform wear, and that's obviously not our current stance.
Sure.
And I think that over time that there's been renewed pride and respect towards uniform wear.
Yeah, that's a really good point about the post Vietnam era in that culture that I haven't thought about. So appreciate that. And if for anybody, I know people from the military might be watching this. PHS, you wear your uniform every day, and that's a culture. But there is a history of the uniform being out of favor at times. So interesting. Well, good. I had some students in my OBC class that were from USUHS, that were at USUHS, and I think that would have been a great route to take. And then you had a long obligation after that. I mean, your life is kind of set for the next 7 years. So after USUHS, you did your residency. So you weren't just, you did family medicine, but you also did that fellowship in
Obstetrics.
Yes. Yep. Thank you. So when you were in Baltimore, was that an extension of USUHS, or was that kind of independent thing, or how did that work?
Yeah, so that was independent. So when medical students finish medical school, they have to apply for residency programs. I was actually, again, in a blessed situation, and students coming out of USUHS have the opportunity to try to match in the military match.
Okay.
Or in the civilian match. And Sean, just checking if you can still hear me. Okay.
Yeah.
A little
skip there. Yeah, I can still hear you.
Okay, very good. Yeah, so going to Baltimore for my residency program was an application process. It's not part of USUHS. I applied for and was accepted to Franklin Square Hospital Center, which had one of the premier family medicine residency programs on the East Coast, including the opportunity for that OB fellowship. Also, no competing pediatric residents. So we ran the newborn nursery, we ran the pediatric floor under, of course, the supervision of attending physicians, but there were no competing residents. So very strong in pediatrics, very strong in OB, and was blessed to be able to attend there. I did want to mention, I think we got cut off earlier, but just to make sure, that we did have the opportunity to do a military match as well. But I wanted to do that civilian match so that I had a broader exposure before going out into Indian health.
For sure. Yeah, that makes sense. So after that, you went to Cherokee, which is in the Nashville area. And for those who don't know, I think there's 12 areas within IHS that are kind of divided up in the country. So Nashville kind of covers the entire east side of the country. But before that, you said, or kind of in the middle of that, I think you said you did the HRSA thing. So was that with the National Health Service Corps?
Yeah, so I did start first at Cherokee, but then when I left Cherokee, I went over to HRSA for 3 years.
Okay.
So that was the National Health Service Corps was really set up with an idea of having opportunities for scholarship or loan repayment physicians, and I was neither of those. So it was sort of an add-on to the National Health Service Corps, having already had my education paid for from Uniform Services University. Did not have to go through the scholarship or loan repayment system, but the Ready Responder Program was a response to 9/11, and the idea being that they would take public health service physicians, place them, and you'll recall with 9/11, all plane flights were grounded, and so all air transportation was stopped. And so one of the ideas was having physicians geographically dispersed who were trained experts in biological warfare, radiation injury, chemical warfare, and as well as disaster recovery. So we went to USAMRIID, trained at AFRI, all of the nation's leading opportunities to train in all of those areas. And 95% of my time was spent as a primary care physician in West Virginia. Maybe 90%, but the rest was training for readiness for disasters, and fortunately did not have another national disaster of that scope within those 3 years. But had there been one, I was the ready responder for West Virginia.
Oh yeah. Okay. So, and that would have been, well, I mean, you had so much deployment experience for hurricanes and stuff later on that probably set you up pretty good.
Absolutely, that training really built on the deployments that I ended up having through the rest of my career, including all the way up to leading the Indian Health Services response operations chief for the COVID response for Indian Health Service. And so having that background and training all the way back to the 2000s, so really 20 years of training and preparedness in deployments and how to manage disasters, I think significantly contributed to my success.
Oh yeah. So let's just jump to that. So the Indian Health Service, again, is the federal healthcare agency that's providing healthcare to American Indians and Alaska Natives. This is going all the way back to treaties way back where this is the government's obligation. There's a lot of health disparities amongst Native Americans. I think throughout my career, I was flabbergasted, not surprised, I guess not surprised. I shouldn't say I was flabbergasted, but it just a little saddened to see that, I think we spend about half the amount per patient at IHS versus the general population. I think I saw a stat that's like we spend about $9,000 per person in the US, where it's only about $4,000 per person at IHS. So it seems really underfunded. There's a lot of challenges, but through the COVID-19 pandemic, Native Americans have had the highest vaccination rate. I think that was back in June or July was that set, and I think it still holds now. And you were spearheading this whole vaccination campaign program for Indian country. So what was that like? I mean, this is like a huge moment in our country, in the world's history, a very vulnerable population. Why was it so successful? Why do you think it was so successful? Like, what was it like? I'm just really curious to hear about the story.
Yeah, well, thank you. One of the things that we knew we had to put in place was, to adapt to the situation of not traveling as much and having strong communications platforms. So developing a regular cadence of communication with tribal leaders, with public health leaders throughout the Indian Health Service, that was key. So we did early consultation with tribes and confer with urban Indian organizations. So these were opportunities to speak with tribal leaders and health system leaders throughout the IHS. We heard early from them what their needs and concerns were around funding and resources and preparedness for the expected increased number of cases, how to prevent cases, but also how to deal with critically ill patients. So there were a number of things that the Indian Health Service undertook. One is listening, of course, to all of these needs, and then taking action to try to fill the gap. So we did create critical care response teams. So this was really in reaction to the recognition that there was nobody else coming from the outside. I mean, you might be able to call for National Guard, but they were going everywhere else. We knew that New York was getting hit really hard, and there were a lot of resources going to the city, and then Oregon and Washington State were drawing a lot of resources, but we had the responsibility for all 574 tribes and nations. And so we set up our own critical care response teams to not only to respond when individuals were sick, but even to pre-deploy if cases were rising, or they didn't have even just the readiness, they could go out and do training for our emergency departments and smaller facilities that needed that refresher on how to manage ventilators, how to manage critical patients, and how to stabilize them and transport them to higher levels of care. So that was key. When the vaccine, even before the vaccine became available, we did a lot of planning together with our federal employees, but also with our tribal leaders and listening to them. There was a lot of discussion about will the vaccine come through the CDC to states and to tribes, or will the vaccine come through the Indian Health Service to tribes? And we again went into a robust consultation to hear the voices of tribal leaders and health leaders. And what we heard was that there was a desire for both, and we had to make the systems work best for tribes and nations to be able to best serve their patients. So, for example, in Alaska, they chose to go through the state. So we helped to facilitate that work with the CDC, making sure that vaccines were distributed to American Indians and Alaska Natives throughout Alaska. However, most of the lower 48, not all, but most, chose to go through the Indian health system. So we got our pharmacists together, really spearheaded a lot of the work in vaccine distribution, and then we did a lot of work with tribal elders, especially around vaccine acceptance, trying to help to deliver that message to American Indians and Alaska Natives that the vaccine is safe and effective, and it still is, and helping to increase our numbers of vaccinations. And again, what was successful there was listening to those tribal voices and then taking action, helping with some public education campaigns, highlighting local tribal leaders getting the vaccine, showing their support for it as well.
So that's really interesting. And I'm, thinking, was that not done on a larger scale, obviously, which is another challenge, listening to people's concerns. What are some specific or unique concerns in the Native community that you think other health professionals or just the general public might not know or understand?
Yeah, thank you. It's a great question as well. So American Indians and Alaska Natives have a trust and treaty relationship with the federal government. And there's a responsibility for the Indian Health Service to provide public health and medical services in response to the treaty obligations of the federal government. So it's not it's not free care; it's really prepaid care through the land and loss of culture that were ceded in those treaty signings with the federal government. So healthcare is really a responsibility of the federal government under those treaties. So the American Indians and Alaska Natives have faced higher incidence of diabetes, alcoholism, substance abuse, mental illness, opioid addiction. So a lot of different conditions affect American Indians and Alaska Natives. And in the past, I think a lot of people look to genetics and saying, well, what are the genetic differences that cause these to happen? But there's been more and more recognition that a lot of chronic disease and associated conditions are actually related to the socioeconomic conditions in which people live, rather than being so highly influenced by the genetics. And don't get me wrong, there are genetic differences, but the differences in socioeconomics are far more striking and far more the causative effect of health disparities. There's also, as you mentioned, the difference in resources. So the funding to the Indian Health Service is significantly less than it is to the population as a whole. And as there has been expansion of Medicaid in some states that has helped to relieve the burden on the most vulnerable, but hasn't solved everything. And there continues to be differences in funding, differences in access to healthcare, transportation, travel, food insecurity, differences in education opportunities, job opportunities. These things impact our health. And if you think about the situations that people encounter living in multi-generational homes, maybe not being in a safe situation at home, when you don't have those basic needs, then going to healthcare for preventive appointments becomes much more difficult.
Yes, absolutely. That's very well said. And so with all those challenges and, the history, what do you think were some of the educational components that you guys were able to provide, or, interventions that made the vaccine more acceptable that might be applicable to other communities in the United States?
Yeah, again, a great question. So we worked with the Johns Hopkins Center for American Indian Health to develop some materials that were specifically focused for the tribal communities that they were working with. That included adapted materials explaining about prevention efforts, so including washing your hands and wearing a mask and waiting at least 6 feet apart. And then as the vaccines became available, again, adopting the informational materials that are predominantly designed for a white middle-class culture, and taking those and making sure that they're in acceptable language, having the right logos, and even the pictures of people that are receiving the vaccine in those materials. There were some children's books that were produced as well to help children dealing with loss and the concerns and the fears that were and still are, unfortunately, very prevalent during the pandemic. A lot of attention to behavioral health and mental health, as the isolation significantly impacted, especially elders and youth being away from school and their friends and all those activities. So a lot of work with other associations, the Association of American Indian Physicians, working with the National Indian Health Board, the National Council for Urban Indian Health. So again, looking for those native-run organizations that have that connection with local leaders that are going to have the most impact on their populations.
Mm-hmm. So we're getting towards the end of our time, but I want to just ask a couple more questions and then loop back to Toedt Health Solutions. But just a couple, rapid fire questions, if you will. What would you say you're most proud of in your 30-year career going through, IHS and being in part of the public health service? What are some things that you're most proud of?
Yeah, thank you. Well, one of the things I'm most proud of is certainly the time I spent with the Eastern Band of Cherokee, both from as a federal health provider early in my career, but also working for the tribe. I continued as a commissioned officer, but on detail to the tribe from 2005 till 2014. And during that time, we saw a lot of improvements in public health, increased vaccination rates, we increased cancer screening rates, we improved diabetes control. That work with the Cherokee community, I'm very proud of the relationships that I was able to develop, and the work I was able to do with that community, using electronic medical records to inform our team-based approach to culturally competent healthcare, was really impactful for me and shaped what I wanted to do for the rest of my career. I'll also say another point of joy for me really had been the work that I did in spreading the electronic medical record, helping physicians go from paper to computers and making that switch. It was very painful and helped to alleviate a lot of their pain in doing that as well. And then less a point of pride, but more a point of, I would say, a strong sense of accomplishment would be in our response rate, getting the highest testing rate for COVID-19 amongst any ethnic group. That, in other words, the American Indians and Alaska Natives were testing at a higher rate than whites, higher rate than Latinos, higher rate than blacks, and in fact, a higher rate than most countries. So that testing rate for COVID-19, and then following that, when the vaccine was developed, getting the highest vaccination rate, that was also an accomplishment of which I'm proud. So thanks.
Me too, coming from IHS, that makes me happy to hear. So thanks for that work. This is something that I come across a lot that I've actually struggled with myself, and I know other officers have. How have you navigated your career as being a public health service officer with the challenges of, like, okay, what is PHS? Like, why are you wearing the uniform? Like, how have you explained that to your friends and family through the years, and how have you navigated kind of that world of being in PHS and IHS, and like, what is public health service? Like, it can almost be like an identity thing. I don't know if you've experienced that, but I'm just kind of interested on your take there. I don't know if you're able to hear me.
Yeah,
Okay.
You're back. So yes, thanks for that question. I think we have to take, as officers, we have to take every opportunity to educate the public and to help to protect and promote and advance the health and safety of the nation, right? So we've got a responsibility in there also to educate those around us, and that's family and friends and others, to help to spread the word of what the public health service does and how it's important for the readiness and response of the nation for disasters like COVID-19, but also for things around the world, like the fight against malaria, the work that's being done on HIV and AIDS, work that's being done on the opioid crisis. The public health service has been at the forefront of each of these, and I think there was some increased awareness at certain parts during the pandemic, but we have to capitalize on our opportunities to continue to get that message across, and to do so with competence and with trust. So.
Yeah, I think the public health service is at the forefront of a lot of major public health crises and issues, and it's sometimes we're just so diluted that there's like one, like, you as an example have led this huge response for COVID-19 vaccination in Indian country, but you're just one officer, right? I mean, there's a lot of officers in IHS, but sometimes people don't know that there's a whole entity of a commissioned corps. So sometimes I think the effect is diluted because we're just kind of spread all over, and there's a structure of the commissioned corps that's a challenge, I think. Do you think that the commissioned corps should be restructured in a way to have more of a concerted approach? Do you think that's an issue? What's kind of your thought about the future of where the corps should go?
Yeah, that's a great question. Again, there's been multiple attempts to reshape how the corps is organized and where it's headed, and I think there was recently some movement in a new direction to improve the base of officers who are in a new reserve corps, and so I think that focusing on increasing our capacity through a reserve corps is very appropriate, very much needed. But at the same time, it has been painful for the active duty officers to see some decrease in promotion rates and other challenges as the corps is being reshaped to include a broader base of reserve officers. And
Yep.
there are a lot of dynamics that are involved. We're in the middle still of a pandemic, and of course, we have with elections, we have changes in leadership and changes in direction, and so those challenges will always be overcome. The Public Health Service has been here for a long time and will be here for many years to come.
Yep. Good. Well, thanks so much for all of that. I mean, there's more questions, more things that I could ask about, but I want to go back to your new endeavor. So you've had an amazing career, so many experiences that are just all over the place in a good way, that just culminate into where you are now. So you're leading Toedt Health Solutions, and you mentioned a couple things that you're subcontracting for the VA and working with some pharmaceutical companies. I'm just curious, because it sounds like you've had a lot of experience within IHS. You mentioned I know when you're in the Great Plains, you mentioned organizational culture change. It sounds like a huge task, especially within IHS. You have the federal government involved, you have the tribes involved, you have Commission Corps involved. There's a lot of players. So I'm just wondering if that's part of your services now. Do you focus on that organizational culture change, which I would imagine is really hard? Do you focus on that, and what are the challenges that you see there, and how can you help with that?
Yeah, great question. So I founded Toedt Health Solutions because I still have a passion for working with underserved populations, and I want to apply my expertise towards helping those who are most in need. So I do have that broad talent stack and that broad leadership experience. So I am offering services in public health leadership, but also health system leadership, health IT and applied clinical informatics, strategic planning and execution, and graduate medical education. So there's probably nobody that's consulting in that broad an area. And I've had some individuals say, well, why don't you pick one and focus on that? But really, at this point in my career, with the experiences that I've had, I really maintain the talent and expertise in those broad areas. So I'm offering those services, and frankly had a lot of interest in all of them. So working with graduate medical education programs, developing relationships with tribes and partner host academic institutions, working in health IT, improving the electronic medical record system, actually some applications with artificial intelligence in terms of healthcare and public health. Actually working some in the public health policy area, working with some Medicaid waivers and creative health solutions for population health. So, so yes, I do have a veteran-owned small business that I just started, and I'm the founder and CEO. At this time, I am the only employee because I just started out, but very excited to see where it takes me.
Well, just one more question, because you mentioned this, and I'm curious, where do you see the, artificial intelligence, and you have a lot of experience in health informatics, and healthcare is super complicated. There's a lot of systems trying to talk to each other. Do you see that as a major challenge right now in healthcare, and what do you think needs to be done going forward to help systems talk and share information?
Yeah. So a quick comment on artificial intelligence. The opportunity that we have now is to use artificial intelligence to take large volumes of data and to begin to look for relationships and present them to us for human thought, right? So we're not expecting AI to make decisions based on information, but to take that information and present it to us in ways that ask questions, or that give us the opportunity to ask questions about that data and about the relationship. So if there are relationships between certain medications and certain outcomes, that does not imply a causative effect, but it certainly can give us the opportunity to take another look. So I think that using artificial intelligence to help to harvest what relationships there are in the health data and then in the public health data to help guide our inquiry and guide our decision making. In terms of health IT overall, there has to be much more focus on interoperability, on transportability of the medical record. There's been a lot of work to try to lay the policy foundation to do that, but the approaches are often decentralized and allow so much variation that the cost becomes prohibitive for systems to try to develop sharing relationships with other systems that don't talk the same health record sharing language, if you will. So having uniformity of protocols for transfer of information will be important to help with that transparency and accountability in healthcare.
You, I think, will be very busy, even after all the years you've been busy. So I think you're the man for the job. This has been a really big treat, and I've really enjoyed listening to your story. So thank you, sir. Is there anything else you would like to leave with the audience or anybody listening? And then also where people can find out more about your business?
Thank you. You know, the most important message I want to say is, you know, please, if you've not gotten the vaccine, if you have questions about it, ask your healthcare provider questions. If you're not sure what to do, make the opportunity for space and conversation. I know it does no good for me to tell the unvaccinated to go get vaccinated. So I'm going to take a step back and say, go talk with your healthcare provider about it. At least have that discussion, have the opportunity for learning and for growth. The vaccines are safe and effective. I do recommend them. I've gotten the vaccine myself personally. And then, you know, together we will get through this pandemic and be a stronger nation for it. Sean, I want to thank you for the opportunity to speak with you, for the wonderful work you do in educating the public about the PHS and the continued focus on the future of the PHS as well. So thank you for that.
Thanks. I appreciate that. And where can people follow you if they want to learn more about Toedt Health Solutions or anything else about you?
Yeah, so I do have a website. You can go to toedthealth.com. Also have a presence on LinkedIn and other social media. But if you start at toedthealth.com, it's got the links for those other platforms.
Perfect. Well, thanks so much, Michael. This has been great. And